Thank you to all the speakers for making such valid points about medicine's innovation and the value of transformation. Now, what I really love about summits that CXO Global organizes is that there are a lot of use case studies that prove proof of concepts. We're going to now be talking about standardized digital quality and safety measures used in performance improvement, payment programs, and public reporting. This case study is going to be presented by Zahid Butt. So over to you, Zahid.
Okay, good evening and Assalamu alaikum. I'm Dr. Zahid Butt from Medisolve, and I'm speaking with you this morning from the Washington, D.C. area. And I'm going to spend the next 15 to 20 minutes just to give you a very quick update on standardized digital quality measures as they are used in various payment programs as well as in public reporting. So just a word about Medisolve. We are a healthcare analytics company based here in the Washington, D.C. area. We provide software to about 1,600 hospitals in the U.S. and about 5,000 physicians. We have been doing this for the last 20 years or so. So there's a lot of experience in quality measurement and reporting of data. So the first question really that arises is, why should one measure quality? And the short answer is that if you cannot measure it, you cannot improve it, whether it's healthcare quality or gas efficiency or petrol efficiency or whatever you want to improve, you have to measure it and then improve it. This was not something that is new. It was stated such by Lord Kelvin almost a little over 100 years ago. And so the basic premise has not changed. The key is to determine what to measure, how to measure, how often to measure, and then once you measure, what to do with it. So I will share with you some of the things that are being done in the area of measuring healthcare quality. So this is sort of a very idealized cycle where, generally speaking, there is some sort of research here on the upper left-hand side, which could be even some clinical trials or some expert opinion, which often will result in certain guidelines. And there is great interest nowadays to digitize those guidelines and provide them as clinical decision support at the point of care. With or without clinical decision support, the practicing clinicians shown here in number 4 in some fashion incorporate those guidelines into their treatment plans. And then once the care is delivered, usually the measurement starts. So generally speaking, measurement is by nature a retrospective analysis. And so quality measures are one form of measurement. There are 2 main measurements that are done under quality measurement. We measure outcomes of conditions or patients, and then we also measure the processes of care. And the ideal is to understand which processes of care have the best outcomes through real data. There is great interest on part of the payer community in the United States, because a lot of the payments to the healthcare system are made by the insurance carriers. And the largest payer in the United States is the federal government through its Medicare and Medicaid programs. And so Congress is involved in many of these quality and value type of measurement programs. This is just a timeline of some of the legislation that has direct impact on the measurement of quality that is tied to payments. And so you can see as far back as 2008, Congress has been passing legislation in the top row. And once Congress passes that legislation, the Department of Health and Human Services then implements it, it interprets it, and then it implements it for the providers of care, whether they are physicians or hospitals. So for example, in 2010, the Affordable Care Act was passed, which is also more commonly known as Obamacare. And out of that came 3 value-based payment programs that link payment by the government to quality of care as measured by the metrics. The Hospital Value-Based Payment Program, the Hospital Readmission Reduction Program, and the Hospital Acquired Condition Reduction Program. So all these programs here in green were the result of legislation that was passed in 2010, and they are still in existence. So the government does have a big role to play in much of this, and they also help foster the infrastructure that is needed to support this. Another thing that the government has been keenly interested in more recently has been how to convert these quality metrics data into something that is easily used by the consumers of healthcare. And so these metrics are used then to convert performance into star rating, for example. And here's an example of the star rating, the overall star rating of the performance of quality and safety as shown in this example. And the consumer is also encouraged to use these data when they are able to choose between providers. So needless to say, between this and the payments, quality reporting is a pretty big deal for both hospitals and providers and physicians in the United States. So traditionally, quality measurement for many years has been done by abstraction of data from medical records, whether it's paper records or later on the electronic quality measures that started using the electronic clinical quality measures, because the traditional way of extracting data by human beings reading through the charts was felt to be very costly and not sustainable. So as the electronic clinical quality measures came on the scene, it was felt that why don't we just use the data that is being collected as the process of care goes on, and use that as a secondary mechanism for quality measures. So I will focus on these electronic clinical quality measures that are shown in the middle because this is where we are today. I will also mention a few things about where we're going, which is the so-called digital quality measures. And the difference is that the electronic clinical quality measures were primarily using electronic health record data, whereas it is conceived that digital quality measures will have a broad set of data, not just from EHRs, but from outside the EHRs. However, the key point in all of this is that the data need to be standardized. And so these are some of the electronic clinical quality measure basics. There is a standardized way of creating the specification that's shown on the right-hand side. Health quality measure format is a HL7 standard for specifying these measures. There's a heavy use of terminology and code sets, which are listed up here. And then the electronic clinical quality measure specification is applied to the data that are collected as part of the care. And then a result is generated. And there are two formats that are part of the HL7 reporting format: quality reporting data architecture category 1 at the patient level, and category 3 is at the aggregate level. And so those get reported to either CMS or other payers or any other entities that are collecting these data. And so to get from that paper record to the electronic clinical quality measures has been almost a 10-year journey. We've had a front seat in this throughout. And so I won't go into the various milestones, but they just show that it is not an easy process to put this infrastructure and make it work and be implemented. And so as we go forward, there is now sort of great emphasis on the fast healthcare interoperability resources, or more commonly known as FHIR standards for interoperability, to be used for quality reporting as well. And so this is what is envisioned in the FHIR standards, that the EHRs would produce data that's standardized and mapped to the FHIR data model. And then the specifications will use the data from this FHIR data model shown here and will generate the, so in essence, it's doing the same thing, but it is doing it in a slightly different way. The most recent entrant in the type of quality measures that up until now have not received too much attention is the patient-reported outcomes. And so the idea here is that the patient reports their own experience of care, as well as they report on data that's generated by the patient, for example, in wearables and other devices that are increasingly being used by patients to generate data. The idea is that that is also a very important and rich source of data that needs to produce measures that are known as PRO-PMs, or patient-reported outcomes performance measures. The National Quality Forum has convened a task force, a technical expert panel. I'm a member of this technical expert panel that created this technical guidance, and you can search on the National Quality Forum website and read this technical guidance report. The project has now been extended to one more year to try to add more digital measure concepts into this. And so we will be, the NQF will be issuing a second update to this report with the digital measures in mind. And so here's a sort of schematic of how the patient-generated health data is going to be moving through the system. It'll have connections mostly through APIs with EHRs, patient portals. Mobile health apps are a very important aspect whenever there is any kind of patient-generated data. And of course, there is going to be a need to aggregate those data and to connect those to the EHRs for them to become a source for quality measurement and reporting. CMS is putting a lot of emphasis on this at this time. And so how does the quality management work in the future? It's very important, certainly in the US, to support all the digital and the so-called hybrid digital measures. It needs a lot of different resources and skill sets for effective team structures. It needs informatics people, data management, data transformation, and certainly experts who understand quality measurement and improvement. And in many cases, there is a need to partner with a third party if the healthcare entity does not have resources. And so It also takes a long time to get this stuff in and working properly. So if you are planning to do something in 2023, you have to give yourself at least a year and a half before you can actually have something in place. And so this was just a very sort of high level introduction to this topic. It's a very exciting area, a lot of interest in this, both at the standards level as well as the policy making level. And so I believe I had about 15 minutes to kind of give you this introduction, and I'm happy to answer any questions if there is an opportunity to answer questions. I don't know if the format allows for that. And thank you very much for giving me this opportunity.